Good morning. Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live from the Dolph Simons Family Studio. I got it all out one time without a mistake. Awesome.
One
breath. I am joined by Dr. Dana Hawkinson, our Medical Director of Infection Prevention and Control. We have two very special guests with us today. Mayor David Alvey joins us from the Unified Government. Mayor, welcome this morning. And Dr. Jed Gorlin. Thank you. And Dr. Jed Gorlin, the Medical Director of the Community Blood Center. We know what Dr. Gorlin's going to say because we know we need help with plasma and blood donations. We'll return to that. But first, Doc Hawk.
Yes.
Ouch.
Very bad.
Very bad.
Not good. Kind of what we had predicted a few weeks back with the continued increase in cases. We were really good. At one point we got down to 23. Yesterday we were 31. It jumped up over the weekend. Today we're at 39 patients.
That's our high.
Yep.
That's our high, and it's rising. So we anticipate that's going to go higher.
Yeah, 11 in the ICU, 8 of those on the ventilator. There was a very good question this morning. Well, what are the ages? Well, unfortunately, we do have an 18-year-old patient in here. Ages in the ICU range from 30 to 86. With on the ventilator, the range of people in those 8 ventilators, 30 to 72 years old.
Ouch.
So otherwise in the hospital, in general, taking out that 18-year-old, it's 30 to 99 years old. So there is a range. It's every decade, and it's even the young people.
We just, and we'll talk about it at the end of the program again today, you have the power. You have the ability to make this thing stop. But it's going to take more will, and it's going to take more following the pillars of infection control. It's hard, right? It is hard.
It's difficult.
But it's not complicated. And you hear all these competing voices out there. It's really not complicated. It's the same thing we've been doing for over 100 years with infection prevention and control. Wear a mask, wash your hands, stay distanced, do the things that worked in the flu pandemic of 1918. Yeah. We can stop it in its tracks. And by it, of course, I'm talking about COVID-19, before it stops you. Jed Gorlin, how are things at the blood bank?
They're good. They've been better, and you can help make it better.
About that, tell us how to make it better, and how are we doing on our blood supply right now?
So the blood supply is good. We are fortunate to be in the generous Midwest, where our blood donors are indeed above average. That said, since mid-March, we have stopped all blood drives. We used to collect a lot at schools, churches, businesses. We've just started over the last month and a half or so some of the blood drives at businesses, but even those are reduced. So it is challenging, and especially going into Labor Day weekend will be particularly challenging. Elective surgeries are restarting, and sadly, so is some of the mayhem.
Yeah, we don't like the mayhem, but what we're hoping is that the blood supply stays. So how many days blood supply do you have right now?
So it depends upon blood type. We'd love to have more than 3. We're sitting around 3. Obviously, O-neg is always a challenge. We want to start a dating group and introduce the O-negs to each other because they breed true.
You bet.
I'm kidding about that.
Yeah. So, Mayor Alvey, how are things going in Wyandotte County as far as the incidence of COVID-19? And tell us what the county's doing, where we are in Wyandotte in response to this pandemic. Mayor Alvey, are you on mute by chance?
Yes, I was. Thank you. I would say that in general, we are making progress against the spread of COVID-19. Especially since the mask order went into effect, we do have some places where I think people don't still understand the necessity of the mask and how it's really an act of kindness and charity towards others, especially those closest to you, those you come in most contact with. I think we have seen our rolling average now decline to about 43 cases per day, which actually is just about where we were on April 10th when we had our first real spike and started coming down from there. But then, of course, it spiked up again because people began to feel that the crisis was over and they could get more active and get out there and really not pay attention to what the virus is, what it does, and take the appropriate measures.
Yeah, that's a spooky part, isn't it? So, Mayor, one of the things I saw coming out of Kansas yesterday was data that suggested that those counties where the mask order is in place have a 40% lower or 30 to 40% lower incidence of COVID-19 than those counties where there is not a mask order. Are you familiar with that? And I think it came out from Lee Norman. Any way that, can you help us address that?
Yes. So I think, of course, that was what the projection was. I had seen before the mask order went into effect here that I think Rex Archer had mentioned in a press conference that in those localities that had a mask order, if they did not have a mask order, 80% of those localities saw an increase in cases. In those locations that there was a mask order, but masks were only used maybe by the employees in a shop or a business, the 70% of those localities saw an increase. But in those areas where masks were required of everyone, there was a 25% decrease in transmission. So that's what we anticipated. And honestly, I would expect that the number 40 to 30 would be better than that. But I think what we're seeing is there are some who are still not complying, and that we're still seeing some people continue to gather in large groups where the transmission risk is much higher.
Well, and I think the other thing, Mayor, is that how long ago did that mask order go into effect?
Oh my gosh, I've lost all track of time since COVID.
It was like the first
1 eon ago.
It's early in July, and I think what we're it's going to take another month to really measure that effect, because you've got to get through second and third order spread, and in order for the mask to fully take effect, it will require time, and I just think it's actually remarkable it's had the effect it has already, and I think it's just such good news that you guys that you and others around have taken that measure, because from just a healthcare perspective and a physician perspective and medical perspective, there is absolutely no question about the importance of mask wearing. And anyone who thinks it's not important is deluding themselves because they just don't want to wear it, or they think it's become a political statement, or any of that other bunch of baloney. The reality is that mask wearing has been protecting patients in hospitals for generations. A surgeon and a nurse would never perform a surgery on a patient without a mask on, because that mask keeps that patient safe. It is no different around COVID-19.
Yeah. And I think it's good. You know, initially when we had it, we just had data from other countries. So we had population data from other countries. And there are still people who, we're not like them. They aren't like us. That's not our country. Now we are getting down to community level in the United States, community level data about counties that are doing it and counties that are, or cities that are and cities that aren't. And we're seeing that data, and it's real life, and it's in our face every day. So hopefully that will be one more piece of information to help kind of change the culture and change people's
and Dr. Gorlin, I'm going to bet that you guys have masks on throughout blood drives.
We do, and we ask that blood donors have masks as well. We ask that all blood donations are by appointment. That allows us to maintain social distancing. And we, clean and scrub stuff between donors. We still haven't figured out how to be 6 feet away when drawing the blood, but we're working on it.
Good luck with that part. But if you got the masks on, really, I think you're in good hands. So, well, Jill, let's see what questions we have initially from media this morning. Any questions? Nothing there. So let's turn to our listening audience, because we know you're already busy with questions coming in.
That's correct. I want to start with one, though, that came in while you were having the discussion about numbers on masks. Kay says that she is concerned that she hears a lot of people saying that the numbers are being inflated just to make the mask argument stronger. That I guess you might be lying. Are you and Dr. Norman lying?
No. I can't speak for Dr. Norman, although he doesn't lie. I can speak for myself, and Dana can speak for himself. There is absolutely no reason we need to lie, because the science is overwhelming here, people. You got to give up on this. There is I just don't understand why when we've been wearing masks for generations, suddenly, when we suggest that you should wear a mask because it's a global pandemic with the most dangerous virus we've ever encountered, we think that suddenly mask wearing is wrong or is political. That's just baloney. That's just stupid. And at some level, you have to accept that medical science has proven time and time and time and time and time again that wearing a mask keeps you safe. It keeps you safe when you're having an operating room. You don't want the surgeon leaning over, spitting into your wound. That just doesn't make any sense, does it? So why would you not want to do that? And remember, go take a look at those freezer videos. We're going to go back because I see so many people wearing a mask over their mouth and not over their nose to demonstrate that that really doesn't help. But you just look at that breath cloud around you and think about it when you go outside on a cold winter's morning, especially a moist cold winter's morning, and the first thing you do is you exhale, you see your breath. Where that breath is going. It's going out into the air. That's where the virus is. And so when we're in the freezer and we're showing you that breath going all around us, well, we're doing that in order to make you understand that the mask stops it. It brings it to a dead stop. It's why it is so important to do that, along with physical distancing, washing your hands. And it's frustrating, I think, to those of us who are in the healthcare field, Dana, to think that people still believe we need to inflate numbers or make things up. Why do we need to do that? We don't need to do that. The truth is the truth.
Yep. No, we see it every day. We have it now, We've had family members in here. We know that people can shed this virus and infect other people when they don't have any symptoms whatsoever. So, infecting one person is bad. Infecting members of a family are bad. We do have an adult child and parent in the hospital right now. The adult child is on the ventilator. So again, we know that it affects individuals, it affects families. It is not political. It is not for us to make more money. We aren't making any more money. The hospital has lost money. We've talked about that.
We're making a lot less money right now.
So we have science to back us up. We have peer-reviewed articles that show a decrease in infections, in hospitalizations, and deaths for those communities that wear masks. If not, then we have the conscientious appeal. Do what's right for your neighbors, for your community, for your family. And there's ethical justification for wearing masks. It's not a political thing. It doesn't mean you're weak. It just means you're doing the right thing.
What's that thing? Do unto others as you would have them do unto you. Mm-hmm. I don't want you doing unto me your coronavirus.
Right.
That's really,
absolutely.
That's kind of the analysis here. Don't do that to me. So, Mayor, I suspect you're going to feel the same way. We don't need to make up the numbers in order to make the case.
No, I think it's the general mistrust. I find that more and more people seem to be distanced from what they consider to be the centers of power and influence. And so when you don't have direct contact with, let's say, elected officials or folks in your position, you begin to feel distant, and then people begin to become cynical and suspicious. And again, I have no reason at all to inflate numbers. I would never tolerate such a thing. It's impossible to really to continually is come back to the virus. What is it? What is this phenomenon, and what is it doing? How is it moving, and what must we do in response to prevent the transmission? And I find that when I engage in Facebook with people who question the efficacy of masks or the reason for it, I simply say this: well, if the question I have is, which of your loved ones are you willing to infect? Just point out that person right now and say, yes, I'm willing for that person, my son, my daughter, my mother, my grandmother, to be infected and I'm going to take the risk of not wearing a mask because I could pick it up. I could be, asymptomatic and still shed the virus. But I'm willing for my mother, for instance, to come down with the virus and take the risk. And I tell people, you really have to look at this almost as Russian roulette. No one knows if they're infected by the virus, what will happen to them or to others. The range of symptoms, we've been focusing on the death rate, which is important, but thankfully, because as we proceed through, doctors, the medical community have come up with better treatments to prevent death. And yet what we're seeing is a whole range of other symptoms, not even up to death, that really impair lung functioning, neurological functioning, kidney functioning, that there are all sorts of a complex of symptoms and long-term effects that we are just now starting to gather information on. And again, which of my loved ones or people close to me am I willing to infect because I choose not to wear a mask? And if you can demonstrate to me that you do not have the virus and will never have the virus, more power to you, but you simply don't have the medical experience or the science behind to back up any such claim. So I think I want to emphasize to people there is no reason why we would inflate these numbers. We want to get things moving. We've had to take a huge hit in the revenues in Wyandotte County, and we've had to cut budget and install furloughs and do all sorts of things just to be able to make our budget. As sure the hospital has to do the same. And we want to move beyond this. And if folks would just simply wear the mask, maintain social distancing, wash hands, and not engage in large gatherings that you can't control the spread, we could really limit this and get a handle on it. It's basically saying, if I'm going to have to chase down a tiger, I'd rather chase down a tiger cub than a full-grown tiger. If we can reduce the size of this spread to manageable levels that we can really target with testing and contact tracing and then isolation, we could stomp this thing out. And it is, as you said, it's very simple. The measures we need to take are very simple. The less we do the simple measures, the more drastic measures have to be used, whether it's medical intervention or, stay at home, those kinds of things. Let's use the mask. Let's maintain social distancing. Let's do those simple things so we don't have to do the much more hard and sometimes really impossible tasks.
Yeah, that's exactly right. And I think you and I probably share the same frustration. I can hear it in both of our voices that people doubt this. And it's just not that hard. Again, I just come back to the basic truth, in the flu pandemic of 1918, nice article in the Kansas City Star this last weekend, a couple weekends ago, about the flu pandemic, about the differences between Kansas City and St. Louis. People wear masks. It's the same fight, and it's the same silliness, because what happened is those people who didn't wear masks died, and those people who do wear masks don't.
Yeah.
And it's not 100%, but it's darn good. So in a world where we don't yet have vaccines, our therapies are really not directed at outpatients because we don't have that yet. It's really directed at inpatients. And even with those therapies, people die. And we're gonna review that next Monday. We're gonna go through our deaths here at KU. We've had 45 deaths to date. By this end of the week, it'll be higher. We're gonna go through those deaths. And we're gonna show you who died, not the names, of course, but how old they were, their underlying conditions. We're gonna spend this session on that because we need you to know it's real. And I thought, Mayor, you did a great job. Which one of those people do you want to infect? Who do you not like in your family that you want to give COVID to? That's
right.
That's really, what a terrible thought, right? And the thing is that you have the power, right? You, not us. You have the power. You can stop COVID in its tracks. We talked about yesterday, COVID is not a superhero. It is not a supervillain. It does not have superpowers, but you do. You have the ability to stop it. The question is, are you going to do it?
And I think Mayor Alvey brought up a very good point too. So if you do not want to subscribe to the science, which is very pure and blatant and it's out there, if you don't want to subscribe to your social conscience, the next thing is economics.
Right. Do you want to keep businesses open?
Right. Look at all these businesses. Look at the NCAA stopping the tournament. Look at the MLB and the NBA. There would be no reason why they wanted to stop their revenue.
Look at college football hanging in the balance right now.
And so it's a very real thing.
It is real.
Absolutely.
All right, Lori wants to know, with all the treatments that we have for COVID-19, she talks about remdesivir, convalescent plasma, steroids, and anticoagulants. Why are so many people still dying of COVID-19?
Yeah, because those therapies aren't, they're not great. They're all incremental. meaning they all make a little bit of difference, but none of them are really directed at the virus per se, except remdesivir. And it's okay. It's not, frankly, remdesivir is not a great drug. It's an okay drug. It just happens we talk about it a lot because it's the only antiviral drug we've got right now. And I go back to the early days of AIDS, and because I don't have a lot of hair on top, I've been around since then. And for those of us that lived through the AIDS epidemic of the late 80s and early 90s, we will remember that people died. There were a lot of patients that died, and 80% of hospitalized HIV patients in the late 80s and early 90s were dying. And the first drug, AZT, came out, and it saved a few lives. It was better, but it wasn't great. It had a ton of side effects. And then some other drugs came out, and some more drugs came out. Now, 20 years later, we have really good therapy for HIV. We have really good therapy for hepatitis C. It took 20 years to get there. So how did people stay safe from hep C and HIV? Well, not everybody did. But the way you could stay safe was by being smart. And that's really the story with COVID. We will get good therapy against COVID. We will beat COVID. But in the meantime, the power belongs to you.
Yeah, absolutely. Very good point. Remdesivir is a good drug. It's not great. We have to remember it was approved based on the fact that it has seemed to get hospitalized patients out of the hospital in 11 versus 15 days, not showing really significance in severe patients.
And it didn't change mortality. And so that's the other point. Now, I had to have a bigger study, and there's a lot. It probably does change mortality, but we didn't. The study was to look at how many days you got out earlier, but it wasn't powered, which means there wasn't enough people in there to find a huge mortality difference.
So it's a good drug, but it's an adjunct to everything else, to the anticoagulation, to the steroids that help reduce the inflammation and immune dysregulation. We have to remember that it's not just the viral effects on the body, but it's the immune dysregulation that causes all the inflammatory process a week to 10 days after the infection. So.
Dr. Gorlin, I'm going to guess you and I are probably about the same age. I'm going to suggest that you and I probably grew up a little bit during the AIDS epidemic and pandemic at the time. Do you draw any correlation between AIDS and coronavirus? I do that a lot because I'm old, and the younger people like Hawkeye here, they don't remember it as well.
So my wife was the first hemophilia nurse practitioner at Boston Children's Hospital, where she insisted on using this brand new stuff called heat-treated factor, and that was created to help decrease hepatitis. In fact, it was lousy at preventing hepatitis C, but it was very good at preventing HIV. So absolutely, I certainly go back to that era. But let's talk about convalescent plasma. The first Nobel Prize in medicine way back in the early 1900s was for convalescent plasma for influenza. You're absolutely right. It is not a home run. It's probably a bunt single. However, Mike Joyner of Mayo just did a meta-analysis of multiple small published studies, and there does appear to be both mortality and morbidity benefit if the convalescent plasma is given early. Most patients make their own antibodies by 7 to 10 days, so it shouldn't surprise you that it doesn't seem to have much effect well on into the illness. People already have plenty of antibody then, and adding a little bit more isn't going to change that. However, there are now some outpatient studies, one done out of ERs called C3PO. I am not making that up. And Johns Hopkins also has a prophylactic study going on. The results are not out yet, so I can't make any efficacy claims. But in the meantime, we've been charged by the federal government to create a strategic stockpile over 300,000 units. And I think they're doing that because there is reason to believe that it helps or might help. In addition, it is the starting product for making hyperimmune globulin, which would be very concentrated antibodies. Whether it's transfused directly or whether it goes into hyperimmune globulin, in either case, the thing we need are people that have recovered. And what's clear is people who have actually been sick have much higher antibody and neutralizing antibody levels than people who are just, tested at random. So that's why our blood center is not doing just the mass screening tests as an incentive, because those are not the convalescent plasma units we need. We need it from people who have truly recovered.
Yeah, and I think to your point, historically, we didn't have therapy initially for COVID-19 because we didn't understand it well enough, and as a result, the death rates were 30 to 40% in a hospital of hospitalized patients. Now our death rate is 8 to 9%, which is still extraordinarily high for a disease. And we don't admit a lot of people where we expect 10% of them to die.
Yeah.
And yet that's where we are today, and that's with steroids and convalescent plasma and all and remdesivir, et cetera. And so even with that therapy, we still have a 10% death rate, and that's still too high, Dana.
Yeah, absolutely. I appreciate his points. They're very good. In the treatment of this, it's going to be an algorithm. So there's going to be stepwise, and what you get is going to be important as when you get it in the course of illness. Certainly, if I were diagnosed today, I would absolutely want the convalescent plasma before I would develop symptoms. I think the timing of all these things is going to be important, whether you're talking about the steroids, the antiviral, or the convalescent plasma, or whatever else comes down the line.
Marcia wants to know if you can speak to COVID and myocarditis.
Oh, yeah. And I think we're going to probably have a little session later this week on this exact topic, because it's really the breaking news, right? You know, July the 25th, an article was published in JAMA Cardiology that sort of pointed out things that I think we were all afraid of. And that said that in looking at a population of 100 patients, I believe it was 60 or 70 of them had inflammation on an MRI. Now let's back up a little bit. Myocarditis is inflammation of the heart muscle. And we've known that, we've seen that in influenza, we've seen it in adenovirus, we've seen it in simple novel, or not the novel, but the simple coronavirus. You can get it from just about any viral illness. And in some cases, and they're pretty unusual, but in some cases that can lead to a thinning and a distension of the heart and a lack of function in the heart, and even to heart failure and a need for heart transplant and death. And bad heart rhythms that can lead to death. So all those things are bad, and so that's myocarditis is something you don't really want to have. So what they found in this study, if it's out of Frankfurt, Germany, is that in 100 patients, 60 or 70% of them had myocarditis on an MRI. Now, an MRI is very sensitive, and it picks it up really well, more so than an echocardiogram. All those patients had some bump in their troponin enzyme, which is a marker of heart inflammation. Now, fast forward into the United States. We don't know what the rate of myocarditis is here. We've not studied it, but that was an astonishingly high rate, I think, to say that 60 or 70% of patients who had recovered from coronavirus after 10 weeks from mild to moderate disease. So we're not talking about all just hospitalized. Most of those patients were outpatients and never had to have been hospitalized. The average age is in the mid-40s, I believe. And so all of that is to say that myocarditis post-COVID is a real threat. The controversy now that is coming about is that in college athletics, we don't know the outcome of myocarditis. And we don't know that if a high-impact sport could worsen the damage to the heart, and we don't know what high-intensity exercise might be doing to a heart that's already slightly inflamed. All of those are leading to questions about the safety of returning to high-performance sports right now until we understand myocarditis and the course of myocarditis in patients who have had COVID a little bit better. We are screening athletes at KU, and I know Major League Baseball and the NFL do the same things. They look at, if you've had COVID disease, they look to see if you have an enzyme elevation, how your EKG looks, and how your echocardiogram looks. But unfortunately, those are all what we call blunt instruments, meaning that they don't get into the heart tissue and tell you exactly what's going on. MRI is a little more sensitive, but even so, it's a relatively blunt look. And our fear is that we could be missing a lot of disease that we can't see and we can't test for. And that can include very small blood vessel clots inside the heart that lead to more heart damage. So there's a lot of concern right now about myocarditis. And I think we're going to try and address this more specifically later this week, because it is a breaking story, and I think it's clearly impacting the landscape of college sports. And questions are going to be raised then about high school sports and others. We're going to take a swing at that later this week.
Yeah, I think that's very interesting and good points. To stick with the heart, to your point, those were mild to moderate disease. In autopsy, so in patients who have died, we know that when they look at the heart, there is inflammatory cells there. We know that there is microthrombi, or very small blood clots. And some of them have shown also staining for the virus, but very few. But in general, a lot of them have actually shown detection of the RNA. So that's just in the heart itself. We know that in asymptomatic people, so people who have no symptoms from the disease, they actually have changes on their CAT scan in their lungs. So there's inflammatory process going on in their lungs. which is right next to your heart, which is another vital organ. And we know that you have changes even in mild to moderate disease in your brain as well. So we are looking at all those organ systems and what is the short-term effect and what is the long-term effect of that. And again, a lot of this is going to be an inflammatory process caused by the inflammatory cells and the infection.
In response to the virus.
Yep.
So I think that this would be a challenging question for those who are involved in sports and in other activities. And I think the problem is we just don't know what we don't know right now.
Correct.
And you've heard us say many times, beginning with Dr. Jessica Callender-Rich, that we're building the airplane while we fly it. And we learn a lot when we do that, and sometimes we're right, and sometimes the parts don't fit. The key is to stay in the air, and so to stay safe, and I think that's really important. Dr. Garland, any thoughts about that myocarditis and inflammation with your history and your background in the community blood bank?
I can only say I'm also a pediatrician by background, and listen in on the periodic pediatric calls. And one of the unique things we're seeing in pediatrics is this post-COVID hyperinflammatory syndrome that has some resemblance to Kawasaki's, but is actually quite distinct in many ways. But myocarditis, among many other inflammatory processes, is very striking part. The highest von Willebrand's level ever seen at University of Minnesota was in a pediatric hyperinflammatory child.
Yeah, so all things we're going to have to be very cognizant of as we go forward.
Evelina wants you to speak about a recent mass study that was ranking whether gaiters that you pull up and the sports people wear work and bandanas.
Yeah. Okay, Dana.
That's good. So, I think it was a very good study. It is one study. It did show various ability of the mask to act as a barrier. Certainly the N95, the fitted N95 was the best. Which in the healthcare system, we have fit testing, so we make sure that there is a seal around the N95. A little bit different than going to the hardware store and buying one and just using one. Also, next was the surgical mask. And then after that, there was gradations about homemade masks with 2 or 3 cotton levels. And then, as you had mentioned, the gaiters and the bandana. Certainly the gaiters and the bandana seem less. In fact, what they surmised was that you actually decreased the droplet size or filtered it out as you went out. But that being said, again, it's one study. Any barrier is better than no barrier. We would like you to have any sort of mask on to reduce the amount of droplet spread if you can. Moving forward, I think more studies still need to be done and further recommendations on the community mask wearing as far as what kind of masks still need to be done. But most all of the masks that you can purchase, aside from the gaiters or the homemade bandanas, and this is not different than a study that was published earlier that showed a bandana probably wasn't as good as maybe folding over a cloth 2 or 3 times and doing that. So it's not totally novel. It's a little bit more in detail about masks in general, but I think any sort of barrier is better than nothing.
Mayor Alvey, from your standpoint in Wyandotte County, do you care what the barrier is?
Well, absolutely. I mean, I think, as you said, so many of the steps we take are incremental, whether it's in treatment or prevention. And so we have to tally up all the incremental steps so that we can get higher and higher prevention of the transmission of the disease and better treatment. So I think it's absolutely, again, I think what I saw was that you prefer, if you're going to make a cloth mask, you would make it out of, let's say, a 500 thread count sheet rather than a T-shirt, because again, it stops the transmission of the droplets and maybe even some of the aerosolized particles. Or anything we can do to improve the performance, we need to do, again, because if we can continue to do the simple things, we don't have to take the hard hits later, which do come.
And myocarditis is one of those.
We have a lot of teachers on the thread this morning, and they are asking questions that are related to mask wearing. Some of them are, and they want you to speak to kind of different ages. I think maybe not necessarily high schoolers, but one's got 18 kindergartners, and she wants to know, if I put masks on all of them, do I have to make them just sit in their chairs, or can they get around, play, we wash their hands, they play some more, we wash their hands, they play some more, we wash their hands? What do you say?
This is a complex
This is a
question.
hard one. And Jen, I'm going to turn to you too, because you're a pediatrician. Your kid
Yeah.
stuck with us in part. But just to start out, Dana, I think what we know is that if you're above the age of 3 or 4, you should wear a mask. We thought kids were less infectious, less of a vector, but then the data started rolling in that they have high viral titers. So help us resolve that a little bit. And then we're going to get to the masking
especially
question.
those under 10, I think there's still okay data suggesting that they are less apt to spread the virus, whether that's they don't have the power in their exertion when they're breathing, and of course when they're yelling or laughing they will. So that's the medical standpoint. The other is their emotional, physical, and social development as well. I think that, the standard right now is still really under 10 or less apt to spread it as much as compared to over 10. That certainly goes against the face of every other respiratory disease that we know about and gastrointestinal disease. But I think we really have to focus on the mask wearing, because we know that at that age they can wear a mask if they're trained to do that, and it's a slow training. But again, any mask, any barrier is better than nothing, and they still need to develop. And so I'd like to see what Dr. Gorlin thinks about that.
Dr.
as well.
Gorlin, thoughts? You probably a lot of ways.
It's really hard. You're trying to create a balance, and I think the importance of socialization, the importance of getting education in early is so key. And if that results in a slightly higher spread rate, then maybe it's worth it if we can be more rigorous in other areas. I certainly appreciate. I think the teacher has a truly impossible job. One of my daughters was Teach for America in the South Side of Chicago, and just trying to keep those kids in their seats. And they were 9th and 10th graders was nigh on impossible. So you do what you can do. You encourage mask wearing. You absolutely encourage the hand washing. It will be imperfect at best. But we also know that realistically, online learning for kindergarten is really, really hard.
Yeah, it is. There's just no easy answer to this one, and I wish that there was. But first of all, 18 kindergartners. Oh my God, I couldn't even take care of my one. And so, hats off to you as a teacher for doing that. Second thing is, as Dr. Gorlin said, it's just hard. And I think the more they wear the mask, the safer things are. It's all a matter of degree. You do the best you can and try and stay as safe as you can.
A follow-up to that is, one wants to know, if I'm a teacher and I wear a mask, should I also wear a shield to prevent students who are not wearing masks infecting me?
That's also a great question, Dana.
Absolutely.
And I think, my simple answer to this is the more precaution you can take, the better off you are. And so if a face shield, if you have that available and want to wear one, it does both things. It helps protect you and it does help protect the other folks. It's not nearly as effective as a mask, let's be clear. But in adding to a mask, it can certainly help. And so too, if you don't want to wear a face shield, eye goggles are probably good enough.
Yeah, we've always advocated for eye protection. So whether that's
I always have them here with
face
me.
shield or the hardware store or Amazon goggles,
We got them.
we got
Hey,
them.
do we have the same ones? I think we
No.
might just about. They're pretty
bit.
similar. Yeah, well, okay.
But they do have top protection and they have
do.
side protection.
All right, let me model this around the side.
Again, these were given to me by a colleague who bought them at a hardware store.
Yeah, and I'll tell you, so last night I ran up to the floor to see a patient, and I realized after I started walking out, I saw the nurse over there, I didn't have my eye goggles. I have my glasses on, but not my eye goggles. And I was like, oh my God, I'm naked. I felt terrible. I felt like I go home to take a bath. This is so wrong.
Right.
And it's funny how when you get used to doing it, it becomes part of your habit, and they really are an important part
And
of your habit.
they do have they do fog up a little bit.
They do.
You have to adjust it and get used to that. But that is one more step of protection that you can take for yourself. And so we've always advocated for that.
Okay, last question, Jill.
Julie wants to know, why are vaccines for measles, mumps, polio different, not lifelong, than a flu or potential COVID vaccine? None of them are lifelong, are they?
That's a very good question.
Okay, it's up your alley there.
So she mentioned measles, mumps, which is a live virus. It's just a matter of, number one, what type of virus is it? Is it a DNA virus? Is it an RNA virus? Influenza and coronavirus are RNA viruses, so they tend to mutate or change a little bit more. what type of vaccine is it? Is it a live virus vaccine? Is it a killed virus vaccine? Or is it a subunit or a piece? And all those things are very important. And to what point, if we are just using a piece of the virus or the bacteria, do we have to add something to it so that you get an immune response of both your cellular immune system, but also your humoral immune system? So we want T cells and antibodies. So there are just very different details in there as to why some vaccines are different, why some are longer, such as, again, the tetanus vaccine, but that is, bacterial, or some are shorter, and you have to get boosters or get shots every year. And Dr. Gorlin may have some more comments about that as well. But basically, it's just different viruses, different ways to produce the virus and make the virus, hoping to all get T cell and antibody responses.
Dr. Gorlin.
So in large studies, we're finding that about 95 to 97% of people who have recovered have antibodies. That's why we screen for antibodies before we send out the convalescent plasma. But what that means is 3 to 5% of the people got over it without having significant levels of antibodies. So clearly there is more than one mechanism of recovering from COVID. And so to the extent that you can stimulate the phagocytes, so to speak, stimulate the immune system, you are more likely to achieve a lasting benefit. And as you mentioned, we're already seeing some genetic variation in this virus. And so it does not appear to be as quick as influenza, which has a multi-segment genome, which can really mutate fast, but it's already mutating. So one doesn't want to put all our eggs on a single vaccine, for example.
Yeah. So final thoughts from this morning. Mayor Alvey, what can we do to make Wyandotte County a safer place?
Again, I just think we have to keep getting the message out and have people, do a self-check, do a self-reflection. Why am I resistant to wearing a mask? What is it about the virus I don't understand? Who am I willing to risk their lives? I could be asymptomatic carrying the virus. If I'm not wearing a mask, I could be spreading it. Who among my friends and family am I willing to play Russian roulette with?
Just to say a special message out there, maybe to teachers, and I'm going to, and I, as I was sitting here, I was remembering that you have a long history at Rockhurst High School, and were involved in administration and working with faculty there. Special message to teachers about trying to keep them safe.
Well, I think it's what you would, any precaution you can take, you need to do. And I think you have to continue to bring your concerns to your administration to let them know what your level of fear is, what your level of concern is. They need to help you problem solve. It's really, because it is a novel coronavirus in a different situation, you have to continue to look at it day to day, moment to moment, to say what new information is being presented to us that we have to really take into account and integrate into our plans. So it's going to require a lot of work. I think what we have to do is be very sensitive. If there is an outbreak, that administrations have to be able to look at that and say, we're going to take the appropriate measures, because we have to protect our loved ones, our staff members, our employees. We all deserve that level of care.
Yeah, yes, we do. Okay. Dr. Gorlin, any final thoughts from this morning?
If you have had significant COVID, please, if you're an eligible blood donor, go to our website, www.cbckc.org. Sign up to be a convalescent plasma donor. If you have not, we need your donations anyway. It's the only donation that comes out of your arm and not your wallet. We're all about community, and we're a community blood center.
Out of your arm, but not your wallet. I'll tell you what. If I do have the misfortune of getting COVID-19, I'm hospitalized, I want convalescent plasma. Mm-hmm. So to all of those out there who could be donors, please do. And to all of you who could be blood donors, it is the gift of life.
Yeah.
Final thoughts.
We have seen the infections continue to rise. We've always said that hospitalizations follow that, and whether it's 2 or 3 weeks, we are starting to see that now. We are seeing the infections here in our hospital rise. Hopefully there can be a stop to that, but we need to continue to endorse and get out the message of masking, social distancing, not going out if you're ill, and hand washing, so that we can stop the amounts of illness, hospitalizations, and death, because we need to turn that corner now.
It is. Hey, you can donate blood on our campus later this month from 7 a.m. to 7 p.m. August 27th and 28th over in our health education building. Go to donate.savealifenow.org to learn more and to help sign up. Also tomorrow, Dr. Mario Castro and Dr. Barbara Pahud, the latter person is a pediatric infectious disease doctor at Children's, and Dr. Castro is back with us. He is our Division Director of Pulmonary Critical Care Medicine and Vice Chair for Clinical Translational Research, and they're going to give an update on our vaccine trial. A couple of parting thoughts today. So first, some great masking picture. Julie writes that masking up with two of my daughters at a neighborhood concert in Boulder. Dr. Sandra Stites brought them into the world. I'm not going to read the last part.
Dr. Steve Stites is keeping them safe. Yes. Go on.
Hey, folks, listen, a long time ago, my mother-in-law and I were out in the back porch of our house, and I was going on about where my kids could go to school or shouldn't go to school and this and that, and I had all these, I had all these great thoughts. My mother-in-law looked at me and said, Stephen, it's not about you. It's about your kids. We're here with you tomorrow. Just remember, there's still no place like home. We'll see you then.